Good afternoon, everybody. Welcome to the Supported Return to Training webinars for updates and clinical refreshers during the pandemic. I'm Kerry Chadwick. I'm one of the Supported Return to Training National Clinical Fellows and one of the paediatric registrars within the West Midlands. We're about to start our first presentation, which is about COVID-19 in children, giving us an update. I'd like to introduce Prasad Nagakumar, who is a paediatric respiratory consultant at Birmingham Women's and Children's Hospital, who's kindly agreed to talk to us this evening. Over to you, Prasad.
Thank you. I need to share the slides, Kerry. And just let me. Okay, thank you.
Yep, that's perfect. We can see those. Brilliant.
Brilliant. Thank you. Thanks for the invite. I'm going to talk about the pediatric aspects of COVID-19. And I wanted to give a bit of a background sort of about my interest with COVID. It all started earlier on in February when I got a background of interest in respiratory immunology. I did my MD at Imperial in severe asthma in children. And early February, my 10-year-old son, he sort of his school was taking on a ski trip to Switzerland. And that was probably sometime late February. And this was a stage where we had very little information about this condition, and there were a lot of anxieties about whether he needs to kind of go on a trip or not. And when I started speaking to people at that stage, where I think sort of the cases were increasing in Italy, we hadn't seen much in this country, and there were a couple of sort of experts I spoke to, people I know through my work, and it was quite interesting. Very earlier on, this disease seems to be slightly different. In a way, it wasn't affecting children sort of that much. And as it happens, a few weeks later, I think I had sort of my symptoms of COVID. Obviously, there was kind of no routine tests available for everyone at that stage, so I had to isolate myself. And rather than worrying about sort of what's going to happen to me, I thought sort of to take the mind off, let's look at what happens to the children, because I can't kind of concentrate on things which I don't have control on. And also we look after a number of very complex respiratory patients with extremely rare disorders. And we wanted to look at sort of the implications of this condition in not only in children, but also the ones who have an underlying significant respiratory condition. And that involved kind of looking into a lot of data, which was very minimal at that stage, but mainly through sort of in a way having a chat with colleagues in other parts of Europe where this disease was already sort of in a way was increasing in numbers. And I started sharing these ideas with my colleagues, my respiratory colleague Satish Rao, who's also the Deputy Chief Medical Officer for the Trust. He came up with an idea called COVID Think Tank, where a group of clinicians, we discuss any issues which comes through the Trust. We support the Trust in terms of processes and policies just based on the available evidence. And for this talk, I would like to particularly thank Hari Krishna, who's an intensive care consultant, and Liam McCarthy, who most of you know is a very well-known urology surgeon, and very well supported by Jeremy Kirk from R&D. So there's the background for my interest in COVID. And as I said, sort of in a way, particularly with this condition, wherever we should treat children as small adults, particularly when it comes to therapies, especially to do with COVID. And what's interesting is generally kids get blamed for any viruses. They are the ones who spread, and that's not unusual. If you look at sort of in a way the data, your normal sort of, in a way, seasonal flu. It affects the extreme of age, either the very younger ones or people who are old. And then people thought that with this condition, it's going to be kind of, in a way, a similar picture. Now, I'm not going to talk about sort of, in a way, the anatomy of this virus, but what I want to highlight is it's not the virus which spreads, it's the people who spread the virus. It's not in the best interest of the virus to kill people, because it has to survive, and it can survive only when people are alive. And before we go to the next step, just to refresh, we know that sort of the diagnostic tests, I'm talking about what's available in UK, currently is a PCR test. Normally it's done through sort of an nasopharyngeal or throat swab. And we know that sort of, in a way, it has sort of around 70% sensitivity. However, if you get a sample from either sputum or a bronchoalveolar lavage, the sensitivity increases. But when pertaining to children, it's very unusual for us to get sort of sputum or bronchoalveolar lavage routinely. So we rely generally on the nasopharyngeal and throat swabs. An antibody test which may help in diagnosing if someone already had a COVID-19 infection. This is not yet kind of available for routine use. What was very clear from very earlier on, and then if you look at these two papers that were from very early March, is that sort of the infection rate in kids was probably very less. So this I'm talking sometime in data from March. This data from our Japanese individuals, around 300 individuals from Japan, or different age groups. It shows that kids, particularly, very few of them are affected. And South Korea, which has sort of in a way had a very different but very effective screening and managing methodologies, out of 9,000 individuals who were tested for COVID, just 1.1% of those were less than sort of 10 years, and none of them had a severe infection. So from very earlier on, so this data is from early March. So it was quite obvious that children they get less infection with COVID, and the infection is very mild. And there was also some evidence that sort of in a way you can't blame them for spreading the infection. So very earlier on. And more importantly, the data from China and Italy, it showed that the case fatality, the fatal cases of COVID in children was extremely low. And on this paper shows that particularly when you look at children sort of 0 to 9, both in China and in Italy, there were no deaths which are directly reported to as a consequence of COVID. And this is based on big number of patients who were tested. So from very earlier on, it was obvious that things were slightly different with this virus. Kids cannot be blamed for spreading this or getting a severe infection. And this is a more recent data from New York, which has 70% of all cases in US. And if you see, there are very few in children. And also there are no reported deaths. So this is around sort of a 10 days old data, but I'm just trying to illustrate the difference when you look at sort of in a way elderly people or compare them to the pediatric data. What about the UK? I mean, we have multiple sources where we can get sort of in a way the pediatric data. The main, probably the most robust, is the ISREC 4C. This is the International Severe Acute Respiratory and Emerging Infection Consortium. They produce, this involves anyone who's older than 28 days. And it's a very robust data set. And they are getting a lot of data, both clinical data and to some extent sort of a laboratory data to get sort of a good picture of this disease. And pertaining specifically to pediatrics, we got the Royal College our Pediatric Royal College service evaluation audit. The Public Health England, obviously, they collect all the data. And more importantly, in pediatrics, there are a lot of societies, and being a respiratory versus fibrosis trust, things like that, who work up along with the Intensive Care Society, who are collecting their own data. So this is probably the most updated data from ISRIC. I think it says 20,000, but today morning I heard that already 23,000 patients. So these, you need to remember that these are anyone older than 28 days who are admitted to any hospital in the UK. And what's interesting is if you look at the bottom of this graph, it's very clear that less than 2% of all the cases with COVID-19 admitted to the hospital in this country are children, and less than 1% are very young. So this is a bit different to, for example, if you look at the other flu vaccine, flu or influenza sort of viruses, or usually the ones which we see in winter with RSV or any of the other common viruses. And then if you look at the Royal College sort of website, they update this generally once a week. And bearing in mind that this data is dependent on clinicians putting the data into it, so it's not as robust as the ISRIC data, but we got sort of in a way some information about 95 kids who are admitted to the hospital. It also tells you here at the bottom the admission rate, and I'm sure that sort of there's still a lot of children data which needs to be inputted, but it gives you a bit of a sense of the breakdown of these 95 kids, and interestingly, 9 of them, it looks like they became positive while they were inpatient for some other reason. Some of them could be because they're long stays in the hospital, and most of them were quite young. The median age was 17 months. However, the median length of stay in the hospital was 3 days, so which is quite interesting if you compare to the adult data what we hear about. And more interestingly, more than sort of 50% of kids who are admitted to the hospital, this is based on a sample size of 95, more than half of them, they had no comorbidities. And interestingly, as you can see, most of the patients are looked after by the general pediatricians in contrast to adults. Very, very few of my core respiratory patients actually have this illness. And there is a number of other comorbidities which are listed here: respiratory, oncology, cardiac, neurological problems, i.e. children with an associated comorbidities who have been admitted with this illness. And what's striking is that majority of them, as 77% of patients, children who were admitted to the hospital who had a COVID positive test, they did not require any kind of respiratory support. Oxygen was given in 16% out of these 95, and very, very, very few kids unfortunately ended up in ITU. So I mean, the reason why I'm saying unfortunate is in pediatrics, you have one child going to ITU. I think for us, it's not a good sign. And compare this to the adult data. I mean, the most updated sort of data is out of patients, adults admitted to the hospital with COVID, half of them, they get better, a third, they die, and the third are still in the hospital. Some of them may not do well. And comparing that to the pediatric data we have, there is a big difference, which is good for children. What about the intensive care data? I mean, Harry shared this with me. As of today, I think around 44 children who were admitted to intensive care. This does not mean that there are 44 children with COVID in PICU today. This is the total number of children. Some of them have been discharged home. Some of them are still in ITU. And even in America, there are 150 kids in PICU admitted with COVID. For us, in children, death of one child is too many. However, there were 8 deaths which have been attributed to COVID, out of which I think 3, as far as we know, they were very well before. And if you compare that to the US data, this is again 10 days old, there were 15 deaths in PICU, but many of these intensive care units were also looking after young adults. So the data is going to come out. So moving on, what about kids with comorbidities? Because in the adult world, there is a lot of talk about the implications of comorbid conditions on the outcome with COVID. And there are reports coming out, particularly in children who are immunosuppressed, either because of the post-transplant, liver transplant, etc., inflammatory bowel disease or malignancy. And the available data, it shows that these kids are not at a higher, more risk at getting infection compared to someone of their age group. And more importantly, they don't get severe infections. I mean, this is very early, but if you look at sort of the data from Italy, where there's a center which looks after around 700 kids with post-liver transplant or with chronic liver diseases who are on immunosuppressants, they had a handful of admissions, all of them with mild illnesses. And respiratory conditions, particularly the worries about kids with asthma, interstitial lung disease, cystic fibrosis, but we're not seeing many of them being positive. In fact, the numbers are really small. What about neonates? Again, the data, there is published data from around 50 neonates. Generally, it's said to be a mild disease. Some of them, they have required oxygen or hydroxygen therapy. And probably there is no vertical transmission, although there are a couple of case reports where they have found this IgM antibody in the cord blood that needs to be looked into. So the summary of this part of talk is that in children, the disease rate is low. They are at low risk of severe infection. Low risk of, although I haven't talked about it, I'll put this in summary. There are studies which show that the transmission from children to other children or adults is very low. And in fact, I think sort of there is more emerging evidence that the transmission of this infection to children is predominantly from adults or between adults rather than adulthood, rather than a child to the adult, which is quite kind of very interesting. The question is, why is it mild? I mean, it's good for us, but what's the sort of way hypothesis behind it? I don't think we have fully understood. There's a lot of work going on, but the couple of things what we need to work around is what's the current evidence favors this ACE2 receptor. Which is predominantly present in a number of organs, but predominantly the lungs, where this virus attaches and uses this as a vehicle to get into the cell. And what's known is that this ACE2 receptor is not fully expressed in children's lungs, and you need to be aware that the lung alveoli, it grows till around 12 to 14 years of age. So as the child goes into the second decade, these receptors probably they reach what's seen in an adult. So that's probably the reason why we are seeing more infection, or to some extent severe infection in adulthood. The other thing what's been attributed is kids have robust immunity. And there's also talk about immune imprinting. So kids by age 3 or 4, most of them that would have been exposed to the other classical coronavirus, and whether previous exposure to those viruses would have given them a little bit of immunity, and these things have to be looked into. So I'll go a little bit detail into the pathophysiology. This is a picture of an alveoli, and if you imagine the SARS virus entering the alveoli, normally the mechanism is it's gobbled up by the alveolar macrophages. Which again release few cytokines, which excite a lot of T cells, and then this is the basic antiviral immunity, which kills most of these viruses. So in 85% of the cases, generally this mechanism is enough to get rid of the virus. So this happens during the first week when someone sort of becomes symptomatic. However, unfortunately, in around 15% of individuals who are infected, the immune system, for whatever reason, goes into an overdrive. and then can result in what's deemed as cytokine storm or macrophage activation syndrome. And if you look at the slide on the left, which is, this is the airway epithelium, quite nicely, silent T cells with good numbers. And when someone when they get hit with this COVID virus, there is breakage of the epithelium. The macrophages, which are the first line of defense, the scavenger cells, they gobble up these viruses. They also release a lot of cytokines, which again excise the number of T cells. And most of them, as I said, it should stop here. But in a small proportion of patients, unfortunately, this cytokine release goes into an overdrive. You can see that the number of cells here compared to the ones here is very little. So this results generally in lymphopenia. And most of these cytokines enter the bloodstream, creating a systemic inflammatory response. So this is currently in a way the accepted mechanism, but it's not fully understood. And these ACE2 receptors are present in a number of other organs, which explains why you can see symptoms because of the other diseases, including other organs, including intestine, the heart, and the other organs of the body. I would recommend people who are on Twitter every week, the fantastic team at the Birmingham University. I'm part of this group too, who produce a very good one-slide summary of not only of just the infection, the infection progression, but also about any updates about drugs and things so on. And obviously for pediatrics, I don't think you can get any better information or up-to-date information then don't forget the bubbles. I would recommend people looking into these two to get more updated information. So we talked about a bit of epidemiology and pathophysiology. So what are the clinical features? Are they different to what we see in adults? And this is again quite earlier on, very early paper from China, where half of the kids, they had in a way cough. Fever was present in around 71% of patients, and there were a number of other very non-specific infections. What we need to be mindful is this is a respiratory enterovirus. So 5% of even the previous in a way SARS infections, 5% of the cases, they do develop non-respiratory symptoms as a primary symptom. So this is again the data from the Royal College audit of 95 patients, and you can see that around 80%, more than 80% of patients, children, they had fever. The other non-specific features like lethargy, they had a lot of coryzal symptoms, had rash. There were reported seizures and various other symptoms, but still it looks like in a way fever and coryzal symptoms are significant. However, as I said, this is a respiratory enterovirus, so you are going to see in a small proportion of patients non-classical features, and there are case reports of neurological symptoms. Luckily, they're all been self-limiting. There's a case report of around 5 cases from France. And more recently, you might be aware that there's talk about the systemic inflammatory response, Kawasaki-like syndrome, kids presenting with myalgia, headache, and it's now recognized that any child coming with vomiting, diarrhea, or with an acute abdomen, COVID-19 has to be ruled out. So this I want to touch upon a little bit. We don't have much of the information because over the last couple of days, there have been a lot of the anxiety in the general population about a sudden spike in a very small number of children presenting with a dramatic inflammatory response like syndrome. And I think we need more information about these kids. And I think in a way being cautious and attentive, and when we see a sick child is quite important. This is again very earlier on, a paper from China where they looked into more than 2,000 children, again showing that majority of these children, they have mild to very mild disease, and severe disease is described as someone who needs oxygen. So it's a threshold, particularly when we read these papers from different countries, we need to bear in mind. Now, if you got a child who's positive for COVID, what tests do you do? Now, if they are well, if they have very mild illness, the recommendation is they don't need any tests because most of them are very non-specific. But it's known that in children, although the initial report said that sort of in a way, usually the CRP or the white cell counts are generally okay, but we are seeing sort of in a way kids who may have lymphopenia or high CRP, but they all do well. There is no relationship between the severity of the illness based on this blood test in general, but we need a little bit more information. And unless they are sick, needing HDU or ITU admission, or if they go into oxygen persistent, needing persistent oxygen for more than 2 days, there's no indication for doing chest X-rays. CT is a standard test in adult practice, particularly the initial data from China, because they're not sure what they're dealing with. And if you remember the tests, they're not fully sensitive. So they wanted a combination of tests to give them some indication about the severity of the illness. So most of the initial papers, they all had sort of a CTs which were performed quite earlier on into the illness. But coming to children, even doing an X-ray is not indicated because the changes are very, very, very non-specific. So there's no classical science what's described in adults. For example, there's again of a CT scan of a 14-year-old. As you're aware, the right bottom is what the lung should look like, but here these changes are supposed to be sort of what people have seen in someone who had COVID, but the changes are very non-specific. However, people are looking into the radiological science in children. So the more information we get when we all add them together, probably there could be sort of a little bit more information about the chest X-ray and the CT changes. What do we do? So the treatment, I think it applies to adults too, but concentrating on the children, the mainstay of treatment is supportive care. They need oxygen, or if they need help with feeding, those kind of things. There are no specific drug therapies, in fact, even available in children, unless this is administered as part of a clinical trial or on compassionate grounds. Now, my special interest is looking after children with severe asthma, and there were a lot of anxieties earlier on about the use of steroids, even in adults. That's based on the initial reports, particularly from China, where they used very high dose of intravenous or systemic steroids in adults who are extremely unwell. So there were some anxieties about whether using steroids is going to cause more harm. But you know, the bottom line is someone who's been on steroids, for example, for rheumatological problems or asthmatics, whether it's inhaled steroids or systemic steroids, the advice is for them to carry on. And the same thing, there was a swing with the advice regarding Brufen too, but now it's recommended that sort of in a way, yes, wherever it's necessary, could be used. As I said, there are no specific treatments. I'm not expecting everyone to go through the slide or have any intention of reading through them, but just to show that sort of the magnitude of clinical trials which are currently underway. And this is again sort of 10 days old, but I'm sure that there are more numbers of sort of studies which are particularly looking at therapeutic sort of trials. And I want you guys to just concentrate on this tiny bit here. So if you look, there are probably 2, maybe sort of a double, say 4 studies, which are exclusively looking at children out of sort of hundreds and hundreds of studies. So, you know, because probably kids, we can't find that many to fulfill this criteria for these trials. They're not at present concentrating in children. And the reason why there are so many trials is that because they are looking at up to around 66 kind of druggable human proteins. which could be targeted to help in reducing the severity of this illness. And there is a massive platform trial or recovery study trial which is going on in this country, which offers various therapeutic options. And this is currently sort of only sort of open for adults, but there are some talks about this being kind of available for kids older than 12 years too. So what treatments can we look at? I mean, the thing is, prevention is the best strategy. So we can talk about the vaccines. There are some recommendations in a few countries about taking prophylactic hydroxychloroquine. And if you look at the treatments which have been proposed for adults, predominantly this is all going to be adult sort of data with mild to moderate disease. Either you can use hydroxychloroquine plus or minus azithromycin to block the export of the virions, or use protease inhibitors. These are HIV drugs. In treatment of severe disease, you use the antiviral. It's a new one, which is in the past has been used in Ebola, called remdesivir. And there's a lot of work going on around using sort of monoclonal antibodies, anti-interferon, particularly anti-IL-6, and to some extent anti-IL-1. And I know probably people will be aware of the ongoing studies about using convalescent serum, but generally I'll go through a couple of studies, but there is none of these till date have been proven to be sort of in a way effective. And there is, as part of the recovery platform, there is also sort of an arm where they're trying sort of in a way use of steroids in severe disease, i.e. adults who are admitted to intensive care unit, probably who are needing intubation. I'll spend a couple of minutes about sort of some of the drugs which have been talked about. Hydroxychloroquine, chloroquine, or azithromycin. In the laboratory studies with previous pandemics, it's been known to inhibit viral replication, causes immunomodulation. Azithromycin, anything linked to respiratory, azithromycin is a magic drug, so it should work. But you need to be mindful about the toxicity of these drugs, particularly when they're used in combination. There will be reported deaths because of the cardiac events or overdose. And the interest with hydroxychloroquine and azithromycin has come up. I've tried to avoid using this slide, but every of my presentation it involves this guy, maybe because I want to look at what this guy is doing. So there's a lot of interest. I think this came about because of this very early paper by a group in France, where sort of in a way titles are hydroxychloroquine or azithromycin in treatment of COVID-19 results of an open label, non-randomized clinical trial. What they did was this is the three arms. The black one is no treatment with hydroxychloroquine or plus or minus azithromycin, which they said is a control arm. And this arm in the middle is the ones where patients just had hydroxychloroquine. And on this, the green arm, obviously green sort of is the right color for this. This arm is the one where patients, these are all adult patients who have hydroxychloroquine and azithromycin in combination. And it's fabulous. It looks fantastic that the viral load within 5 days, it is significantly sort of reduced. But when people looked into the paper in a little bit more detail, there are a lot of methodological issues, and all the initial, although there are ongoing studies going on in looking into these two drugs, but I think the interest has waned. I think that there's a study in Brazil which has to be stopped early because of the side effects, but I'm aware that there are a couple of studies which are ongoing. Some of them have been published, which has shown that there is no real difference whether you use this drug on its own or in combination. However, there's still ongoing studies to wait for. So what about the anti-HIV drug? I mean, I'm not used as an antiviral. So this combination of lopinavir and ritonavir, this is again a paper from China, and it's amazing. Even during this sort of pandemic, they're able to do a randomized controlled trial involving 99 patients in the treatment arm and 100 patients in the as a control group, but the study did not show any difference in terms of clinical improvement. So I don't think sort of in a way that this combination therapy is going to be of much of a use. What about the remdesivir? So this is again the advantage of sort of doing a slide at the last minute, because this paper came out late yesterday evening. The first paper, a randomized control trial, again from China, looking at use of remdesivir in patients with moderate to severe COVID. This is again all adults. And unfortunately, there was no clinical benefits noted. However, what they found is that sort of there was a reduction in the time to clinical improvement in those who were treated early, which kind of, although this study was not powered enough to see that difference statistically, because by the time they could kind of in a way carry on doing the study, because of all the other measures, the number of patients in Wuhan had come down significantly. So they're not able to recruit too many to the study. But what's clear is that it does make sense if this drug works, because you know that the viral load probably in patients is going to be high earlier on in the infection. So if you start this drug, 10 or 11 days into the illness, then probably by that time, what we're seeing is the sequelae of the viral infection rather than the virus sitting and waiting for something to happen. So starting antiviral therapy very earlier on might have made some bad changes, but again, I'm aware that there are a number of other trials going on. But as you can see, sort of with progression sort of for a few weeks, if you don't get any definitive answers, then it's unlikely that there is something kind of very drastic going on, but we still need to wait for the final answer. So to summarize this, you can see there's no pediatric data, even adult data in efficacy of any of the therapies, either as prophylaxis to prevent someone getting COVID or in treatment. And as I said, there are very, very few pediatric trials, because to see a difference, you need big numbers with these trials, and then having sort of in a way a handful of patients in ITU. It's good for us, it's good for the child, but from the trial point of view, they're not going to see much of a difference. And as I said, sort of currently, none of these drugs are routinely available unless they're on a clinical trial, or I know that there are some of the drugs which are used on a compassionate basis. And the vaccine, there's a lot of excitement. I know it's already sort of in a way, it has reached the human trial phase. And another general feeling is that yes, even if it's successful, when it's available to everyone, it's not going to be over the next 12 months. And for us in pediatrics, particularly for trainees, people who work in visit hospitals, I think the important thing is if there are any concerns about any child thinking about COVID who's not following the textbook of getting better in few days, please discuss with your regional specialist sort of a center, probably for the infectious diseases team, respiratory, or the ICU team, because some of these drugs are used by pediatricians in visit hospitals. If you look at anti-IL-6 or anti-IL-1, these are rheumatology drugs which are routinely prescribed even as an outpatient basis. But you're dealing with a different sort of in a way scenario here, and we wouldn't recommend someone thinking about starting these drugs in a less supported setting. So before I finish, just wanted to talk about the collateral damage. We have seen that children, they get, luckily, they get less severe infection. They probably sort of cannot be blamed for transmitting the illness, because it's a very nice study that's come out from Australia, where they did detailed contact tracing and tested around 750 school children, around 15 schools in New South Wales, where they had around 9 kids and 9 staff members who were positive for COVID. And I think only 2 of the kids who were screened, they were positive. So this is a very, very, very low risk of transmission of infection. More importantly, they get a mild illness. But as you can imagine, the amount of devastation this virus has caused to everyone directly or indirectly, it's immense. And unfortunately, yes, we all are going to suffer from this, but most of the effect, I think, is going to be on children. Because there are talks about delayed presentation to the hospitals. I got patients sort of away who used to turn up to say hello every 3 weeks to the emergency department. We're not seeing them for months. Of course, we're calling them to make sure that they're all safe, and they all say that they're doing well. But there are reports about kids presenting with, DKA, asthma, a number of other conditions quite late to the hospitals. And more importantly, with the school closures, to some extent, schools suffer probably probably a minority. Schools probably are the safest place for a number of our children. And because of that, the impact of the other social issues, domestic violence and child abuse, those things alone may have a big implication. More importantly, there are thousands of children, yes, it applies to adults too, have been waiting for routine operations, spinal surgeries, hip surgeries, whatever. So with the cancellation of all the routine surgeries, this is going to have a massive, massive impact. And medium term, again, we all have realized how we are going to deliver healthcare, whether it's for good. Probably most of the time, sort of where the changes what we make are going to be for good, but we need to get used to that. And what about the patients who have been waiting to see us in our patient department for tests, or someone who's waiting for the operation? Where are they going to go? It's going to have a massive impact on financially, on the system too. The community services, which a number of our complex patients rely on, is already under stress, under pressure. How that's going to have sort of an impact over the next couple of months to years, is can't imagine. More importantly, the socioeconomic impact. I mean, this is going to have a massive effect on people's lives, people's jobs, and kids, unfortunately, will be the ones who are going to bear the brunt for all these things. So, more importantly, it comes to immediate and the medium health too, is the mental health of these children. So it's going to have, although, to some extent, we are pleased that this infection is not something which has affected sort of in a way children as much as it was thought earlier on, but I think there's going to be a significant sort of in a way collateral damage to our children because of this. To summarize, children account for less than 2% of all COVID-19 cases. Majority of them, even those with underlying medical conditions, they get a mild infection. As I said, there are no specific therapies present. And we need to be aware of the atypical presentations. I mean, common things are common. So say, well, I can't remember the last time I saw Kawasaki disease, but I think what I've been told is spring is a time when you see sort of when there is a peak with Kawasaki sort of cases. They're not seeing much this time. And although sort of we need to be aware of atypical presentations, but also be aware of the common pediatric conditions which still could sort of happen. Some of them may not be related to COVID. I'm talking about the presentation of the children. And as I said, unfortunately, the collateral damage is what worries us. It's going to have significant impact. I mean, we need to start preparing and probably sort of looking at how we can mitigate the effect of these things on our children. Thank you.
Thank you. That was a really brilliant talk and a really good overview of something that's obviously ever developing and changing quite quickly. So thank you very much for that. There's a few questions that I'd like to ask on behalf of the audience, if that's okay.
Yep.
So one is in relation to if you're aware of anyone that is using or any evidence for predictive markers. So for example, serum procalcitonin or IL-6 on admission to kind of try and predict severity of illness or a kind of critical course.
as part of the ISRIC trial, I'm aware that when they go to what's called as a phase 2, they go to sort of the process of collecting sort of some samples. But at present, particularly in pediatrics, I'm not aware of any specific sort of markers, because the issue we were discussing in our center where if you get a sick child, how do we manage? And then because these tests are not routinely done, normally for us it takes a couple of weeks to get the results back. Because the pediatric numbers are so small, unless it's done as part of a research study, I'm aware of the people looking into that, but there's not something which is done routinely at present.
Great. And similarly, is there any role for testing viral load as a predictor?
That's a good question. So what's known, more recent information is that children, their viral load is probably similar to the adults. But these are all kind of in a way, some of them are non-peer reviewed. They're still going through a lot of scrutiny. And I think sort of that's quite, in a way, crucial because we know that if it is, if there are no other mechanisms, i.e. the ACE2 receptor is the main driver for the severity or driving for this virus to get into a cell. These, even in children, it's said that they're present in normal numbers in the upper airway, so they could still sit there. But the change is that they don't kind of in a way go into the lower airway, as it happens in adults. I think it's the information is a bit sketchy, but what we know from a couple of studies, I think is the viral load is similar to the adults.
Great. And just a couple of questions about, I suppose, some more of the atypical presentations that you mentioned. So there's a question here about abdominal pain and GI symptoms, perhaps related to cardiac involvement. Is that something that you've seen or heard about? And is there any more evidence on how we should be kind of measuring this or reacting to those kind of symptoms?
That's a really good question. I think the advice is, I mean, again, it comes from clinicians. This is not sort of an official sort of advice, is if you got anyone presenting with abdominal pain, diarrhea, vomiting, I think sort of they need to be tested, because as you can see that these ACE2 receptors are present in abdomen, in the gut, and obviously heart. And yes, we have, I've heard and I've come across sort of a very, very few patients who are presented with similar symptoms. But I think although some of them, they're still very earlier on going through the treatment, or some of them have just been discharged. But as far as I'm aware, certainly sort of the ones which I'm aware, none of them have been treated. These are all being treated, they've been stabilized.
Okay. And you touched on the role of monoclonal antibodies.
Yeah.
There's obviously been a lot of concern about Kawasaki-like syndrome and inflammation presentations. Is there any role for anakinra or other monoclonal antibodies in that situation? And is there any specific areas where we would try and strictly avoid it?
Again, the information is really, really, really sketchy. I think what's known is in these situations, probably steroids are going to be comparable, more useful. And again, I think that's where the importance of discussing with the specialists is quite crucial, because you'll have some real-time information and changes happen, sometimes a couple of times a day. So there's more new information coming through. And I think being in touch with the specific infectious diseases or PICU specialists in the region is going to be useful. But generally, I mean, I think people are on the side of giving steroids more, unless there are any specific, because most of these things, you can't measure them. I mean, when I say you can't measure them, you can't get the results that quickly. You can measure one, but it does take time.
Okay, and then there is a couple of questions in relation to Black and minority ethnic groups. there's obviously been a lot of concentration on this group in the media, and the higher rates that there seems to be in that group.
Yeah.
Is there a similar set of presentations in children related to ethnic background, and is there any changes in our treatment or our courses? For example, prophylactic HCQ has been mentioned here in one of the questions.
I think it's a really interesting question. Two aspects. One is the historic data they are looking into, because they have seen they've done the analysis on the adult cohort till date, and there is a clear difference. But the pediatric data they're looking for quite close to, and I think there are a lot of other factors, because things like work, and that's where I think comparing different evidence from different countries is quite difficult, because our population, particularly if you look at inner cities, London, Birmingham, or Liverpool, Manchester, wherever, the population is so different. There is deprivation, so people are looking into that. You've got sort of busy families where there are 8 or 10 people living in very close sort of environment. What's the impact of those things? I think it's quite kind of very crucial. Hopefully, over the next few weeks, we should get some information about the impact. The second thing about hydroxychloroquine, I mean, to be honest, I wouldn't sort of recommend, or I wouldn't use this drug routinely. There are arguments that, well, it doesn't cause any side effects. It's one of the drugs which are used very commonly. So why don't we use it? I mean, that's kind of an way. I think in medicine sometimes doing sort of nothing might be more important than prescribing sort of in a way a drug, just because it has commonly no significant side effects. So what's the harm in trying? So I think there is no evidence to say that it makes any kind of difference. I wouldn't sort of in a way go through that route. Because the data, what we're shown today and what's coming out, it's very clear that sort of, even if you see kids who are presenting unwell, most of them, they recover.
Great. And then one last question, which again is a little bit tricky in terms of management and what we know, but there's been some mention of prothrombotic state in COVID-19 cases. And obviously concerns regarding stroke and presentations related to thrombotic states. Is this something that we've seen in the UK? And if so, is there any treatment options for children, bearing in mind that aspirin is sometimes a bit of a difficult choice or not preferred, particularly in febrile children?
That's a really good question. I mean, adults, that seems to be the big change over the last few weeks in terms of the understanding of adulthood. There's more of these patients presenting with this thrombotic events. I know there are sort of in a way a couple of kind of case reports, but I'm not aware of any of these where it's been fatal or people going to the extent of, say, for example, treating these kids who present to ITU with a special treatment. I think that's where I think discussing with a group, this is quite important, because these things are so uncommon in children. It is difficult for us to sort of say whether you use this or not. I think it has to be on a case-to-case basis.
Sure, that's been really, really useful, and some difficult questions there, which I think you've given us really, really useful starting points and answers to. That's all that we kind of have time for in terms of questions. There are still some in the Q&A, and we'll try and answer those if we can and put them up with the recorded session. But thank you very much, Prasad. That was really, really useful. And thank you for your time.
Thank you.
Okay, so we're just going to go to an intermission now, and we'll take a break. We'll try and go outside for some of the clapping at 8 o'clock if we can, so that everyone can catch that show of appreciation. And we'll let you go and have a little bit of a rest, an intermission. I'm about to put up some slides that show a few of the resources that are available for returning doctors. And we'll also, for the next session, be using a Slido poll. So it would be really useful. The code is on the first slide for the intermission. So if you are hoping to listen to the next session, if you could be ready to use that poll so that we can have a little bit of interactivity, that would be absolutely brilliant. And I'll let you go for a break and catch the clapping.